Sometimes, again, another question was like, when is treatment potentially harmful? What can we do? And so we're just always, working through the lens of what is helpful and what is maybe potentially harmful. It's really important to know, especially when we're talking about dementia or major neurocognitive disorder, that really, aside from those reversible conditions early on, there really isn't any medication to date that's making meaningful changes in or preventing mortality or preventing institutionalization, meaning needing to reside in a facility. There's those injectable medications that are new, but they're not really shown to do anything. They come with lots of risk. The other medications we have, like the donepezils and the memantines and all of those other medications, they all can show a little bit of benefit in terms of delaying progression to needing to be placed in a facility, usually on the order of months, but very rarely is it ever years. Like 18 months is, like, generally speaking, what the medication can do. And again, that just delays the amount of time before they need to be put in a facility to be cared for on a 24/7 kind of basis. Potentially, those medications can reduce a little bit of caregiver burnout, reduce a little bit of the behavior component, but it's really not as much as people are hoping for, certainly as much as the commercials on TV would tell you, right? And there's obviously any medication, if there's a medicine out there that a doctor tries to tell you there's no side effect to, you should just immediately find another doctor. And I don't care if that's a supplement, a complementary treatment, or therapy. Like, it's all at a certain point. Basically anything could be potentially harmful if kind of used in abuse. I mean, water, for example, can even be harmful at a certain point, right? And so, and ultimately, as we go through and we're helping folks navigate these things, there's just this growing cumulative impact of hospitalizations and these procedures and these interventions, and just being told time and time again, there's little we can do, and it just becomes very frustrating and difficult. And so ultimately, working with, your team's palliative care, in this instance, geriatricians, your primary care doctors in more rural settings who don't have access to these extra specialties, through neurologies or whatever it might be, just kind of reviewing what is important, what are the things we want to do, and what are the things we don't want to do, because that's what's ultimately going to also help make your life much more manageable if you can make sure that you're doing the things that are important to your loved one. The things that are unhelpful, because I hate to be just completely negative Nancy here. Excuse me if there's anyone named Nancy on here, but this is, want to also just kind of, what are the things that can actually be useful and helpful, and those are, things like treating the depression, correcting the sensory loss, getting them the hearing aids or the eyeglasses they need, reducing the anticholinergic burden. So, everyone and their mother basically is using Benadryl for something in some way. And that's super problematic in terms of the main neurotransmitter that we use in our basically from our chin up is acetylcholine. And that medication, if we're using medications that block that, using Benadryl, for example, to help us sleep, or for nausea, or whatever, or itching, or whatever it might be, again, just kind of ragging on Benadryl here as just kind of the remedy that we all grew up taking. I think we'll let me finish the thought. So blocking that can create confusion. It increases risk of falls, constipation, urinary retention, kind of your vision gets impacted, kind of all these problems just for that one drug that everyone kind of buys over the counter that we think is just so safe. So exercise and mobility preservation. Oh, my thought on Benadryl, sorry. More and more growing literature is, I think we'll find in the next 10 years or so, we'll probably find that Benadryl is not used as often. It may not even be available over the counter, in terms of just recognizing how harmful it can be and not very beneficial. There's just so many better options than that. And that's just one example of one medication that could be potentially harmful. Caregiver support, advanced care planning, safety planning, other things that can actually be, helpful and beneficial. Another question was asked is like kind of prognostication, in terms of, what are we talking about here? How long are we talking about, or what is the journey of this going to look like? Is kind of a natural question that comes next. And ultimately, this is kind of a busy slide. I apologize, but I feel like just kind of laying it all out there quick is the easiest thing here. But ultimately just looking at this kind of median survival component, just look and you can see there's just really this pretty much common theme here that it's like likely somewhere going to be on the order of 6 to 7 years, 6 to 8 years is kind of this thing. Alzheimer's again is very slow early with this very long tail. Is an earlier variant that some people can get that's a little bit more aggressive. There is vascular dementia, which is usually a lot of cardiovascular components along with it, things like strokes and heart attacks. It's a stepwise kind of each time they have another incident, there's kind of this bigger drop. Lewy body dementia and Parkinson's disease, these often get confused. Ultimately, Parkinson's disease is where you start with the motor deficits first, and then you get cognitive impairment later, whereas Lewy body dementia, you start with cognitive impairment, and then later you're getting some of those movement disorders. So it's kind of how that works. And so frontotemporal dementia is kind of the real rough one, where it's like a lot younger, a lot of kind of executive function losses. I don't know if you've ever heard of Phineas P. Gage, but a really interesting story there where a gentleman who works on the railroad kind of basically took a railroad tie type device kind of through the front of his head, totally scrambled who he was, and he became a very aggressive, didn't think of others, kind of lost his ability of his executive function, and just kind of a huge personality change there. But I think ultimately the biggest takeaway I would say is that what we're really pushing these days is kind of more the idea that there's likely not just one single type of cognitive impairment going on. It's likely a mixed component, and this is kind of really what's likely impacting most people. Prolonging life versus prolonging suffering, again, just kind of what is the goal? What are we talking about if we're going to be on this journey for 5, 6, 7, 8 years? I think important to note that most of these folks who have cognitive impairment, they don't really die as a result of the cognitive impairment component. It's not like the brain just stops working, they go to sleep and they don't wake up. It's all the other sequelae of things that can happen. They're developing dysphagia, they're having falls, they're getting infections, they're needing so much medication to manage behaviors that there's kind of an impact there. And so really just the mitigation of all those things and being on that journey and talking about those things early as opposed to late. I had seen some other presentations here before about this palliative care idea and what the heck is it? Lots of conversations around it, and it's easy to get confused because we do lots of different things. And so ultimately, palliative care is just kind of the idea of symptom management, goals of care conversations, working alongside, lots of benefits to reduce conflict and all sorts of problems along that way.